Still see it okay?
We're good to go.
All right, so thanks everybody for joining. I know there's a lot of people online, and I'll try to make this something that is meaningful and useful and relatively easy to understand, even though it's a complicated topic. So this is a financial analysis of a community hospital program. I am a surgeon. I'm not an accountant, so I don't claim to be an expert at billing and that sort of thing. I understand our hospital numbers because I've dug into them and worked with them and asked lots of questions about them and been challenged on them, but I realize that there are different methods of accounting in other healthcare systems. I've given this data or presented this data in over a dozen hospitals over the past year, and a good 50% or more don't have a handle on actually how they're tracking their costs at all or calculating their charges. And the ones that do may actually have a different methodology or accounting system, but the types of things that I'll present here are well established. They're acceptable, even if you can't make an apples-to-apples comparison to your given hospital. If you're trying to figure out how to get a handle on this, then I would say in your hospital you just want to define a method that you can validate and then be consistent with it when you apply it to the different modalities of surgery. So hopefully the questions that I'll answer are, what impact does davinci robotic surgery have on the cost of care? Does it raise or lower the cost of care? Does davinci surgery deliver a greater or lesser margin to the hospital, which is a separate question from cost, or is it too costly for hospitals to provide? And how does the actual clinical quality impact the financial returns? A little snapshot of where I'm from. I'm actually in an independent single specialty group, one of the few, remaining in our area and probably nationwide. The Bellin Health, the primary hospital that I work at and where this data comes from, is a community-based, not-for-profit hospital, about 100 years old, 240 beds. You can see some of the volumes on outpatient visits and surgery, about 350 on the medical staff. About half of the OBGYNs are trained. We have 3 general surgeons, 2 urologists, and 2 cardiothoracic surgeons that are robotically trained, although the cardiothoracic is not terribly active in the past couple of years. A little timeline. This slide has several pieces of information. The green bars show the volume of robotic surgery done year over year at our hospital. You can see that there was a little dip in 2008, and I'll address this later, but then it's been a steady uptick over the past 5 years. We added there's 2 other competitors in the market as far as robotic surgery. An additional hospital came on board here, the 3rd hospital here. We added our 2nd system in 2012, and if I could, draw another column here, for 2013, our volumes are going to approach 600, so they're on this steady uphill climb, and we just added our 3rd system about a month ago. At the bottom, and what the blue line reflects, is the surgeons that are being trained over time. So we started with myself and 2 urologists, added general surgery and the CV surgeons, and then a steady uptick in GYNs, and then we added GYN oncology in 2013. A little bit of comparison of the community and the case mix. So at Bellin, the majority of our cases are GYN, which I think you'll see in this community overall and nationwide. So about 65-70% of all cases are GYN. The rest are urology and general surgery, and we are the only general surgery program up until 2013 in the city. So for the non-accounting types, I'll try to make this clear and be really consistent in my terminology. Charges are actually the bill that the patient gets or the payer gets. It's what the hospital charges for the service. The cost is, a better word, maybe expense. It's the expense for the hospital to deliver that care. The revenue is actually what the hospital gets paid, which we all know is not what we charge or never really related to the cost. And then the contribution margin is the difference between cost and revenue, or another way to look at it is profit. cost ratio is a term that I'll define in further depth, but it's a way that you can calculate the cost on the hospital side. This data began as a project in the end of 11, beginning of 12, to make the pitch to the finance committee in our hospital system to buy a second robot. And some of the facts to maybe answer some questions before they come up: Bellin does not add a surcharge for davinci surgery, so we don't upcharge for davinci. It's coded as a laparoscopic hysterectomy or a laparoscopic cholecystectomy. There's no difference in the way that that's billed out. We do utilize a 3-tier setup charge, but it wouldn't vary from standard laparoscopy to davinci. In other words, if davinci surgery is a 3rd tier for the first minute, so is standard laparoscopy. The difference there would be, say, tubes in the ears or something like that is a lower tier for the first minute. After the first minute, we use a flat minute rate. Some hospitals I've seen have up to 6 tiers of minute charges in the OR. The idea was that we could compare charges between open abdominal, standard laparoscopic, and davinci cases when there were equivalents, that we could calculate the cost of each individual case, including depreciation of capital equipment, which is a question that comes up, and then the net contribution could be calculated. Costs are comparable across systems, I believe. In giving this talk, I want people to focus on costs and not profit. Charges vary based on the way hospitals do charges. Revenue varies based on contracting and payer mix. Margins are not really comparable, but costs internally are comparable. We have similar vendors. We're using the same robots. We're using the same laparoscopic equipment. So when we look at costs, I think we get a more valid, apples-to-apples comparison across you guys listening on the line in our hospital here in Green Bay. So cost ratio. Bellin divides the hospital into cost centers, and then ongoing pooled expenses and charge ratios are calculated. And so if we want to look at the cost of a single case, we can calculate that really quickly by applying these cost ratios to the charges that are given for an individual patient. And if you look at this, the numbers that are highlighted show that in a nursing unit, it costs roughly 40 cents on the dollar per dollar charged. In surgery, it's about 15 cents on a dollar per dollar charged. Now that's going to vary mathematically by changing the charges, changing numerator, and also changing denominator, changing the cost. So it may be a movement of either the numerator or the denominator, but there's quite a bit of variability. If you want to phrase that a different way, in the ICU, this bottom number is the most expensive place for the hospital to take care of patients. The lab has a pretty high margin, it seems. So let's look at some cases, and I've picked some selective cases that are common davinci cases that lots of people have experience with, and they should reflect all of the specialties that may be listening in. So here you can see prostatectomy. Radical open cases compared to all davincis compared to last 50, and last 50 is assumed to be more proficient or at proficiency. This data represents only 2 urologists in the same practice practicing the same way. They did all of these cases, both the radicals and the last 50. What you see is not only is the contribution margin higher for the proficient davinci cases, but I want you to focus on cost. The cost to deliver the care is lower. Now, there is an incremental all davinci versus the last 50, and this, even from a charge basis, is just time. Hospitals charge more over time. Our data spanned a little over 3 years, and so when you look at this, charges went up over 3 years. So the last 50, their charges were higher than they were with their radicals in the early davinci cases. The actual charges to the payer went down, so a $5,000 decrease on the davinci cases versus open cases. Length of stay steadily declined, pretty obvious. An open case, 5 days. A minimally invasive case, 1.9, and that improved over the all da Vinci's with proficiency of the surgeons. A general surgery case, so a Nissen, comparing open, not to different da Vinci cases, but standard straight stick laparoscopy to the last 50 da Vinci's. The most profitable in our hospital are the da Vinci's. What's interesting is it's not about profit but about cost. The cost to deliver that care with the da Vinci's is lower than the standard laparoscopic and substantially lower, 50% lower than the cost for the open cases. The charges are the lowest for the da Vinci. So this, reflects what the payer sees is actually lower by almost 50% from open surgery. So again, shifting surgery, it's common knowledge that shifting surgery from open surgery to minimally invasive improves the cost side of the hospital setting, but it also is seen even when you compare standard laparoscopic to our da Vinci's in our hospital. Length of stay, even better for the da Vinci's than the standard laparoscopic and substantially better than the open, and that's where the cost savings come, and we'll dive into that a little bit deeper as we go on. Operative time, better for the da Vinci's than the laparoscopic, and the way that these operative times are measured is wheels in the OR to wheels out of the OR, so it's consistent with every case. It's not incision time, it's not anesthesia time, but the way that it's measured in our hospital is wheels in to wheels out. Cholecystectomy, a more simple case. I put this one up here even though it's fairly unbalanced. If you look at the case volume, 26 cases on the da Vinci side, 1,500 on the laparoscopic side, and this represents one general surgery group doing all of these, and it also, as you recall from the earlier slides, represents the entire general surgery volume of Green Bay. What was shocking to me on this, what was shocking to me on this is that the cost, the contribution margin was not substantially different, and I asked the group, well, why would you pick da Vinci over laparoscopic? And they said, well, we picked da Vinci's, not for the chip shot cases, but for the ones we didn't think we could complete laparoscopically. These are fairly skilled da Vinci surgeons doing colon cases and Nissens and things like that. So they chose to do their lap choles when the patient might be, hot or infected or acutely ill or multiple prior surgeries or morbidly obese. They would pick to do those on the robot because they felt like they had an advantage. So what you see here is, at least on a subjective analysis, a sicker population of patients operated on with the da Vinci with lower charges, slightly lower costs, and no worse contribution to the system, and lower length of stay for a more acutely ill group of people. Now that's just subjective. We're going to take this data and try and publish it, and from a published standpoint, as we're going through the IRB process, we're actually going to collect some standard clinical data like BMI and comorbidities and previous surgeries and that sort of thing to really validate and compare the different pools of patients that I'm presenting here. Hysterectomy. So it's not so clear because you have different modalities. It's not just strictly that you can compare to open surgery. So there's abdominal, vaginal routes, standard laparoscopic, and then the at proficiency da Vinci's. Again, we want to focus on cost right here. So when you look at the cost compared across the board, yes, the lowest cost is vaginal for the hospital, but the next lowest cost is da Vinci, not standard laparoscopic and not abdominal. So da Vinci, compares very favorably across the board with costs. Of note here, when you look at charges, the actual charges to the payer are similar. The lowest is vaginal, the next is davinci, and then you have LAVH and abdominal up here as the greatest. If you look, and I'll address payer mix quite a bit, later in the presentation, but the reason that charges, because I said in the beginning, people calculate them differently. They may add a charge for davinci that they wouldn't add for other modalities of surgery. We don't do that. The payer mix is also important to point out here that the reimbursement at our hospital is still fairly favorable as a discounted fee for service. So you'll see that no matter what the charges are, the reimbursement is roughly 50%. So even though vaginal is a lower charge and a lower cost, the reimbursement is quite a bit lower too. Because of that, the margin to the hospital is lower. So even though we have a lower cost option here, lower for the system for the payer, lower for cost, the margin is different for the hospital. And that's why you can't compare just profit or contribution margin charges and reimbursement, but the actual supplies used, the time invested, the human resources, all of that sort of thing, the costs are as best as I can see looking at other hospitals, a way to compare, apples to apples. So what does the learning curve do to this? So this is hysterectomies now, going back and adding all davincis versus at proficiency. And what you see is OR time is dramatically increased, 30%. Charges are increased, roughly 30%. Of course, reimbursement is, I've addressed that in the previous slide, it's 50% of charges. Costs go up, though, by 25%. So the learning curve drives up the cost. So let's look at the study.
Dr. Coussons, could we stop for just 1 second? We have a couple of questions that have come in on that section, if you wouldn't mind.
Sure.
Folks, I'm going to apologize if I mispronounce anyone's name. I'm going to do my best here. So the first one comes from Frederica Heller. The question is, we are told by ACOG to use the cheapest form of surgery and only to use robotics for limited cases. Any thoughts? Our department is considering limiting use and having to ask permission prior to scheduling, and we have to defend its use.
So I will touch on that. Remember I said one of the things that I wanted to look at was proficiency and skills and how clinical quality impacts the cost. You'll see that touched on in the learning curve, and you'll see it a little later in the presentation as well. I'm going to make a case that, I'm jumping ahead a little bit, but I'm going to make a case that standard laparoscopic LAVHs and vaginal surgery across the board in the United States. Now, there's obviously isolated pockets where training programs differ and skill sets differ and age of the physicians differ and patients differ and that sort of thing, where you do see a lot of vaginal surgery or you do see a lot of straight stick laparoscopy, but across the board, those two modalities of surgery have not caught on in the past 2 decades and, in fact, may have declined slightly. Until davinci came along, there was no movement in the volume of abdominal surgery done for hysterectomies, and I'm going to address that in a little more detail later in the presentation. So I would say that your case is you have to be proficient at what you do, and if you just pick the hard cases to do, I don't think that that's the best choice. Personally, from a perspective, I did 85% of my surgery vaginally before I started doing davinci, and I was a vaginal surgeon. I felt like it was the least invasive of all minimally invasive surgeries, but I can tell you now from 500 cases that patients do better in many ways with the davinci cases than they did over vaginal surgery. So clinically, I think it's superior as well.
Gotcha. Okay, just a couple more questions on this section. The next one is from Jonathan Sham. Why is reimbursement per dollar charged higher in the davinci cases versus open, specifically Nissen?
Let me go back to that slide and see if I can see exactly what you're asking. Okay, so repeat the question again.
Sure. Why is reimbursement per dollar charged higher in the davinci cases versus open?
Reimbursement per dollar. So I assume that here he's talking about reimbursement is higher in the open cases than it is in the davinci's, or are the charges different? I'm not sure I understand the question completely.
Okay. I'm sorry, Jonathan, if you could type in the question box a clarification on your question. We'll see if we can get back to that maybe later. Next from Patrick Flaherty, what is the assumption for the number of robotic procedures to reach at proficiency?
Excellent question, and that's after I talk about the right study, I'll talk about proficiency.
Got it. Okay.
What's published and what's my opinion? I'll tell you both.
Okay. One last one from Vicki Merrick. What makes the LAVH more expensive when length of stay isn't much more and you don't have cost of davinci instrumentation either?
That's a good question. I will point out some things in our hospital, but in this case, I would, you're talking about $600 difference here. There are incremental times here in the OR. There's 30 minutes of charges in the OR. That might reflect $600 in difference in cost and charges. So I'm not really sure. I haven't delved into that to that level, but I will show you some numbers on that in a slide about 10 more down.
Sounds good. Okay, Dr. Coussons, go ahead and continue. And folks, I will keep collecting questions, and we will continue to get to those. If not in the middle, we'll get to them at the end.
Okay. So the right study is what prompted a lot of this controversy. This is the one that was published in JAMA in early in 2013. I've copied here just the top piece with the source and the authors, as well as the abstract and the objectives. Most people know exactly how this study was designed if they're listening in, but they surveyed a database with about 250,000 patients in it from 2007 to 2010, and they measured factors such as complication rates, blood transfusions, reoperation, length of stay, death, and cost. Their conclusion was between 2007 and 2010, the use of robotic-assisted hysterectomy for benign GYN disorders increased substantially, and that there were similar morbidity profiles, but the use of robotic technology was hamstrung by the fact that it had substantially more costs, and they quantified that at an increase of $2,189. The actual results, when you look at them, a substantial increase in robotic hysterectomy. If you remember the first slide with the increasing blue line, there were 7 GYN surgeons that came on board through our data. So the difference in the last comparison of the at-proficiency robotics and the total robotic hysterectomies reflected that learning curve. So our data said the same thing. When robotics was increasing substantially in our hospital, the costs were 25% higher. So I would not disagree with the Wright study in that sense. But you have to really evaluate it. So there was also a decrease in abdominal hysterectomy. So you can see from prostate, from urology, from general surgery, from GYN, shifting abdominal surgeries out of the hospital into minimally invasive surgeries lowers costs. But in this case, we also have a clinical benefit of fewer abdominal hysterectomies. So I don't know that there really is no advantage like the Wright study reported. So even in hospitals that didn't offer robotics, abdominal hysterectomies declined and LAVH has increased. Kind of an interesting phenomenon. There was shorter length of stay noted for the robotic cases. There were less blood transfusions. There were less readmissions. But what did the headlines report? Costlier robotic sores for hysterectomy and the use of robots for hysterectomy sores, but with little benefit. So I would argue that a decrease in abdominal hysterectomies, shorter length of stays, less readmissions, less transfusions, and other data is kind of bearing this out in all the specialties now, some of the clinical comparisons of robotic surgery. So I would say that those are benefits. We've been through this before. This is a copy of an editorial in the Green Journal from 20 years ago that questioned operative laparoscopy. Is it a surgical advance or a technologic gimmick? When you look at the questions asked in here by the president of ACOG at the time, how does one separate technical feasibility from actual therapeutic benefit? How do we look at quality on this, because it's going to move out of the hospital and surgery centers we have no oversight over? How do we credential and train people? Are these things really experimental? I still run into payers that ask that question about robotics. How do we charge for it? What are the fees? There's no way to build this in, and is it ethical to charge for it? So these same questions came up 20 years ago about standard laparoscopy. They came up again in ACOG in this editorial, and this editorial is pretty much parroting back what the Wright study was, but it says, but he does admit that it does provide shorter hospitalizations, less discomfort, faster return to recovery, but was more expensive. He also used the same data, about $2,000 more per case, and this is what I find ironic, is he says if most women are undergoing hysterectomy for benign conditions each year, if they choose a vaginal or laparoscopic procedure rather than abdominal or robotics, then we could still provide really good minimally invasive care at a lower cost. So how many patients actually choose with the same surgeon, other than maybe using their feet to vote and walking down the street and finding someone else to do their surgery, what their route is? Well, over time, they haven't. Even though these modalities have been available, laparoscopic and vaginal surgery have not caught on, have not changed over time. Still, 7 years ago, 65% of the most common surgery, hysterectomy and GYN surgery, was being performed abdominally. And now, because davinci is caught on and gaining momentum, that's a 50% reduction in abdominal surgery. So if you shift surgery, you can look on a case-by-case basis and maybe say that some costs are higher. We don't see that in our hospital when we do it. But you can also say, as a global approach to it, if you shift these surgeries from abdominal to minimally invasive, not just GYN, but general surgery and prostates as well, you lower the cost of care. Why is that? So when we looked at that cost-to-charge ratio, if you remember, the lowest ratio was in the OR. So charges are higher, and per dollar, it costs less money to provide per charge dollar in the OR. So if you shift your charges to the OR, even though your charges are lower overall for the at proficiency davincis compared to the radicals, the majority of those charges take place in the OR as opposed to on the floor. So in a nursing unit where it costs more money to take care of the patient. I'll point out something here that's overlooked sometimes, but if you look at these other charge centers in the hospital, like lab and pharmacy, peri-op, they go from double digits to single digits. And I'll make a comment about that later. The same thing is seen for Niessens. So there's a large percentage of shift from open cases to davinci off the floor into the OR for the dollars charged and overall lower charges. Hysterectomy, same thing. From open to davinci, and the person asked the question earlier, like, where is the cost savings or where is the cost difference? Here in LEVH, you see in vaginal is kind of a hybrid of charges in the OR and the floor versus davinci. It's the lowest overall of charges in the nursing units. You'll also see across the board decrease in pharmacy and lab charges. So across the board, we saw that charges were lower for davinci cases at proficiency. This is the cost to the payer. The cost for the hospital to deliver that care is lower for the davinci cases, and the resulting contribution margin for the hospital is usually higher, not always, because sometimes there's a payer mix problem in davinci cases, but by an average of all of these cases that we've looked at, and I have data for other ones too, nephrectomies and myomectomies and sacrocolpopexies, I just don't show them in these slides. But across the board, the entire program is about $1,839 positive to the hospital per davinci case. This is not just unique to us. This was published, I think, in April of 12. This is GYN oncology data, and they saw something similar. Overall, hospital costs were lower for robotics compared to the historical open group, and you can see the shift from open to minimally invasive to virtually 100% minimally invasive cases. And the difference was 7,600 to 10,300, even when they recalculated it by adding in capital costs and maintenance costs, it was still tilted in favor of lower costs for the davincis. Not only that, but clinically it was superior. Fewer recurrences in the robotics group, adverse events in the robotics group substantially lower. Time in the OR. So at proficiency, time in the OR decreases. You could see that in the prior slides. I think this is a really unique study because this looked at nothing to do with robotics. This was published in a urology journal, and what they did was they said we're going to be time sensitive. We're going to look at 4 modifications in the OR process and say everybody's going to be worried about time. We're all going to pay attention to it. We're going to use a dedicated anesthesia team, so you don't have to go find anesthesia to start the case. That saves time. Simultaneous processing by the nursing and urology house staff during the case turnover. So some were talking to the patient, some were turning the room over. It wasn't the same group of people dividing their tasks. And they looked at efficiency of use of disposable instrumentation. And what did they see? Every one of these impacted the cost except the anesthesia one, and they saw that there was a net savings of 34 minutes and $2,500 per case. So even when you look at, none of these were unique time-saving steps to robotics, but they happened to do it with a robotic prostatectomy group of patients. And they came up with, if you save time, you save money. The majority of the money here was instrumentation, you'll see, but still, saving time saved money in the OR. So our data actually, when you pull it all together, is about 3,500 case comparisons. It's over about 42 months, 3.5 years, 2008 to early 12. And what we found was that it lowered the length of stay by shifting open cases to minimally invasive. This avoids unnecessary nursing and unit charges and associated costs. And at proficiency, OR times decrease further, lowering that meter that's running in the OR, which lowers the charges. Some other opinions that I pointed out as we went through some of the data. We had lower pharmacy and lab costs, which imply improved clinical outcomes. We actually measured narcotic usage for 50 davinci cases versus 50 other cases pooled together, and that include abdominal, LAVH, and vaginal. And we saw a 55% reduction in narcotic usage. The pharmacy collected the data for us. We also have lower rates of readmission. I'm going to address this a little bit with some of the changing payer environment, but when you look at the readmissions in the future, they're not, when they're surgically complicated, complications of surgery, they're not going to be reimbursed. And these can add astronomically to the cost of care. And we saw that when we collected our data for COMIGs. Faster recovery and faster return to work further lowers the overall cost of the system. This is my own personal observation plus some prior studies in the literature. Growth of a successful davinci program increases surgical volume, and I'll show you how that's shifted in our market, which also leads to increased revenue. And proficiency in davinci cases translates into up to 22% lower charges and lower costs. So learning curves, someone asked about that. So here's the worst case scenario. So this was published this year in the Green Journal in early 2013. And I get the Green Journal and I look for, titles like this, The Learning Curve of Robotic Hysterectomy. Oh, that sounds interesting. I think I'll read it. Oh, look, it happens to be Mayo. It's in my backyard in Rochester. So I read the conclusion. I jump down here and it says that they that operative times and length of stay decreased with 36 months of experience in robotic hysterectomy, whereas complications may not. I'll get back to this cumulative summation analysis, but they provided an objective way to measure proficiency, and they decided this occurred at 91 procedures. And I thought, holy cow, 91 procedures. I mean, I've proctored and observed and trained and followed up and done case observations on about 75 surgeons now, and I just don't see that personally. So I thought this is going to be interesting to read. And then when I read the data, this is, I get down into the mix, and this chart looks at the 8 surgeons that were observed. One fell off the learning curve with only 12 cases in the first 6 months, 4 cases in a year, 16 cases in a year and a half. I would say that that's not adequate to get proficient, and that's what the study showed, is these people sort of fell off the curve. So only one surgeon got over 91 cases. They got 146, surgeon A. So their conclusion was derived on that surgeon. The other surgeon only had 76 cases. So I don't know that this is really a valid study, and I'm not sure how it got published. The other thing is, when I look at this, if I go back and say, well, what was the methodology? When you look at the methodology, they have actually maybe that's the problem with the study, is not the surgeons, but the methodology. They have a really complicated way that they objectively measure and score operative time, complication, length of stay, that sort of thing, this cumulative summation charting. So I don't know that that's a valid way to prove efficiency. Other people that are training residents now, who are training other surgeons, all come up with a similar type of analysis. The new people that are doing single-site surgery have come up with a similar type of approach. What I've seen is similar, and what I would say is that an above-average surgeon is going to be very safe in 5 or 8 maybe cases, and somewhere around 20 to 25, if they can get that done in the first year, or maybe even 6 months would be better, because of sticking with it and not having to play catch up and be behind the curve when they start a case, because it's been an extended period of time. If they do that and they plow through, and then they go for a follow-up with someone who's super good, and do a more advanced case observation, 20 to 25 cases, they should be proficient at that point. Now they need to stay proficient. And I'll use some examples of other industry to say that ongoing skills are just as important as the initial credentialing. So I don't know how well this slide's going to come across and play over the internet, but I think it's kind of an amazing slide to show the growth of robotic surgery in the United States. And the whole point is that the horse is out of the barn, and to question the technology now is not really going to do anything. What we need to do now is approach and say, how can we use this tool that we have to get better clinical outcomes and to provide cheaper care? That's the way that I approach it, and that's the way that we approach it in our hospital. This shows the adoption of davinci. The bubbles show relative case volume, and you'll see that benign hysterectomy and malignant hysterectomy, myomectomy, sacrocolpopexy, GYN is a huge dominating area of the field, with prostates being almost, at market saturation up here. And every case that comes online seems to follow this same growth curve. In our market, roughly 75-80% of all hysterectomies are done with the davinci now. So at the end of 2012, and I don't have any new data newer than this, there was 175 new systems installed. How many went to a first time or were an additional hospital add-on? I know people can't answer right now, so the majority were in hospitals who already had robots. So my question is, if it costs more and it's a problem, on the financial side for hospitals to provide care with davinci, why are the ones that have robots buying more robots? I would say that the hospitals that have a grip on this and are doing it well are going to continue to do it well and continue to grow their program. This illustrates that a little bit. This is the upper Midwest. Here's Green Bay. This red circle is our hospital. This is one across town. The red on the map reflects abdominal hysterectomies relative to the green on the map, which reflects davinci hysterectomies. So flash forward 6 years, 5 years, and you'll see how the green dominates the red. The other thing that's a little bit subtle is this the enlargement or the market share of the circles. They get bigger in the hospitals who are doing more. The other thing that you notice is these small outlying hospitals with this kind of birdshot scattergram of a few abdominal hysterectomies here and there consolidates into the larger areas. This town right here is 1 hour north of Green Bay. In 2010, they did about 250 major GYN cases. In 2012, they did about 30. So a big shift in patients to the areas. This shows relative in Green Bay, Hospital A, Hospital C, Hospital B is Bellin. You can see the little dip, and then it just took off as the center that got known for robotics, and it's pretty much parallel in the growth of the whole city right now with the other two programs flat. And this year, I might have mentioned on the early slide, we'll be approaching 600, so this slope is not changing at all. Payer mix, I've already touched on that a little bit. So traditionally, we've enjoyed a strong contracting relationship with discounted fee-for-service. Even so, costs should be comparable across systems, whereas charges and revenue are not. The impact for P4P, shared risk contracting, DRG-based payments, only make davinci a more compelling choice because when the reimbursement's fixed, the ability for the hospital to lower their costs translates into a higher margin. Obamacare, ACA. I hate to disappoint everybody with this discussion, but I want to show you really what Obamacare is built on. This is a complicated slide. ACAs and some of this are a little bit hard, or accountable care organizations are a little bit hard for people to understand, but this is an actual experience in our hospital. So the way that accountable care organizations work, for those who don't truly understand it, there's a baseline cost to care for a population. In this circumstance, that number is $11,300 per patient. At Bellin, and this is Bellin Theta Health Partners, it's a 3-hospital conglomerate that works on this ACO. The actual cost at baseline was about $8,500, so we were already below the national average. Then over time, which if you go backwards here, this trend is upticking, but over time, the national trend determines the slope right here, what our goal is down here. So if the national trend is whatever it is, flat, increased, decreased, if the trend in your ACO is lower, if the cost ticks down, then you win. If the slope of this line is higher than the slope of this line, you lose. You owe the government money. Now, there are clinical metrics in there that determine how much you lose or how much you win. So even though you bend the cost down, if you don't meet the clinical metrics, you don't get the 70% bonus, you only get a 40% bonus. If the costs tick up and you meet the clinical metrics, you're not penalized as much. But in our system, we bent the cost curve down and met the metrics. So what that meant to my practice personally was a $45,000 bonus, or the actual check was somewhere in about the $5.5 million range paid back to the system. So ACOs are based on bending this cost curve down. So costs are going to be what's looked at in the future, and that's why I want to focus on that so much in our delivery of care. Readmissions, I touched on that earlier. This is just, I'll breeze through this, but basically when you compare complications, infection rates, and readmissions, 68% lower for davinci, 60% lower, 16% lower, 69% fewer transfusions, 92% lower death, 87% lower surgical site infections, faster recovery of those infections, readmissions, 66% lower versus open and 56% lower versus lap. So clinical quality impacts costs also. So Hire is successful in today's environment, will provide the very best care with low complications and be very good at it, fast and efficient. So to the person who answered or asked the question earlier, I don't think that only tackling the hard cases gets you here. I don't think it gets you where you need to be. And in reality, what we've seen is, and what I've seen across the board is, it can't just be the surgeon driving this. The anesthesia has to be on board and not griping about it. Administration does. The nursing staff does. Everybody has to work together to get this done. And it's based on volume, training, simulation, all of the things that we see. This is a very, very esteemed medical journal, Consumer Reports. I'm putting this up here because this is the kind of stuff that's in the public eye, and I don't know how many people saw this, but it was, I don't know, 3 or 4 months ago, early summer, and Consumer Reports compared all the hospitals in the United States, and they took this information over here, including nosocomial infections, surgical site infections, readmissions, major complications, mortality, all the fuzzy, warm feeling things with patients that we're going to be measured on now as quality. And this is all publicly available, CMS data, Leapfrog data, or somewhere. And here's what had happened in Green Bay, Aurora, St. Vincent's, Bellin, and the highest score was Bellin compared across the board, which is where our surgery data here comes from. And not only that, this was the actual highest score in the United States, 74. So even from a super high-level overview, it's not that just, we're trying to do this with robotics. I think robotics are a result of the focused effort of the hospital system as a whole. These are the actual outcomes of my practice davinci cases. Our group is now at about 540 cases. Those are the actual numbers of cuff dehiscence, conversion rates to open. That's 1 dehiscence, 1 conversion to open cases, 0% transfusion rate, 0% infection rate, 3 readmissions and 2 reoperations. I've already talked about length of stay and reduction in narcotic use. And this is better than what's published in the literature. Simulation helps. We have a simulator. It's now for the low-volume surgeon. We're implementing simulation as part of their ongoing credentialing. And it's really nice. It actually does give you feedback on things that are practical and really apply to surgery and the skills and safety profile for robotics. It's not. It happens in other industries. Simulation is what makes the airline industry so safe. Recurrent training and volume. I've spent some time in the Middle East. This is a medical simulation unit in Israel. I trained 20 years ago, and there was nothing like this when I trained. This shows more of that. They even train their field officers. This is very interesting. This is actually a clinical exam room, and to keep your license, even as a primary care doctor in Israel, you have to go to simulation once a year. So we watched, it wasn't a primary care, the actual simulation that was done that I saw here was a GYN surgeon who was going to do a laparoscopic tubal. There was a trocar injury, a bowel injury, a general surgeon had to be called, and the patient wound up with a colostomy after a simple, straightforward lap tubal. Go in and explain that to her. So we had to watch the surgeon go in with a model and explain that to a person sitting in there who was pretending to be the patient. Full ORs for simulation, so it does help with proficiency and safety. So the takeaways, really, by reducing abdominal surgery and shifting to MIS, we lower the cost to deliver care, minimally invasive surgery. No specialty has seen a greater volume shift than benign and malignant GYN surgery with robotics. By improving the skills and efficiency of the team, costs are improved even more, and by lowering complications, readmissions, reoperations, cost is improved even further. A few closing remarks. That's my email. I haven't been kind of watching the question ticker, but I'm sure there's a lot. And due to an overwhelming demand, I'm going to give this talk again in about a month. And I am available to answer questions. Give me 48 hours sometimes to respond to the email, but there's my email if you want to take it down. And then we do host case observations here for surgeons, as well as OR teams and administrators. And our administrators will come and tell their side of this story as well. If there's surgeons on board that are trying to get administrators on board, and if there's administrators who want to kind of hear more from a hospital who is supportive of a growing davinci program. So I'll leave it there and see if Jonathan can shuttle any more questions my way.
Great, Dr. Coussons, thank you very much. I know folks were approaching up on the hour time limit here. Dr. C, if you're willing to stick around for a couple minutes, we'll try and plow through as many of these questions as we can.
Yep.
Okay, so I want to first get back to Jonathan Sham's question from earlier. So his restatement on this, or a clarification, is why is the proportional reimbursement higher in open versus davinci cases?
Proportional reimbursement. So you're going to see a different, let me get back to some of these slides. You're going to see a different case mix with the different specialties that I showed you. When you look at the prostatectomies, let's go up higher. When you look at prostatectomies, the reimbursement, despite the fact that the charges are, $5,000 difference, the reimbursement is relatively flat across here. That's because this is a Medicare population, it's a DRG-based diagnosis. The reimbursement doesn't change relative to the charges. When you look at hysterectomies, I'll skip down to that, it does. This is a discounted fee for service. So if the hospital charges less, it gets paid less. Nissen's are kind of a blend. You can't say it's one payer group over another, but here you'll see that reimbursement goes up as charges goes up, but it's not proportional. It's not double. So this 20 to 40,000 here is almost double, but it's not proportional in reimbursement because here you're going to have some Medicare patients that are fixed-base reimbursement. You're going to have some discounted fee-for-service. It's a blend. I hope that answers your question, but when you look at prostates, it's a good example of a fixed-base payment. When you look at hysterectomies, it's a good a benign hysterectomy is a good a good example of a discounted fee-for-service. So that's the two ends of the spectrum, and a Nissen is kind of a blend.
Next question, again, folks, I apologize if I mispronounce anyone's name here, from Jeff Hemard. How would you suggest addressing the facility that incorporates a surcharge for robotics?
I would please ask them to stop doing it. You don't need to do that to make money doing this. There is no reason to do it. It's only going to be, hampering yourself in the marketplace. We actually have a strategy to go to the payers and show them this data and say, because we're the robotic center, because we're the most efficient, our charges to you are less, you should actually cover our services better than the other hospitals who don't offer this or can't do it as well. So we want to keep this number low is our approach to that.
Okay. From Trupti Mehta, if the code for LAVH and robotics is the same, so why is the cost different?
That's the difference in charges and costs. So the code is the same, but the charges are actually the expense on the hospital side to deliver the care. It has nothing to do with the CPT code or the charge. The charge is basically the same minus, it's not like a professional fee. The hospital charges by the minute in the OR, so the longer you're in the OR, the higher the charge. And then the more supplies they open and the more capital they buy and the more everything goes into that cost. So the actual CPT code, may drive the charge, but it doesn't actually drive the cost.
Okay. Question from Tony Visco at Duke. It is clear that OR time and length of stay influence cost. Assuming these were equal between laparoscopy and robotics, what are the other drivers of cost?
Well, I do think you have the equipment, and I will say this: the way that our hospital accounts for the robot is seen in that cost to charge ratio. So capital equipment depreciation becomes a cost to the OR. The service contract is accounted for elsewhere, but it is also the same way with other surgeries. The reposables are counted in equipment costs, so they're not actually a line item to the patient in our hospital. They are a cost of instrumentation, so they drive that cost ratio. So I think that if you looked at OR time as a whole and length of stay, you're going to see very, very similar costs between surgery modalities.
Okay. Next question from Tyler Lindquist. I think we more or less just addressed this, but specifically what elements are included in the cost in terms of fully allocated? You mentioned depreciation allocation. Is the maintenance contract included as well?
Yeah, that's true.
Okay. From Shane Benner, can you explain the length of stay for davinci at proficiency? Your slide shows 0.0 length of stay.
So not one patient stayed over 20 over. The way that we do our app, my app proficiency davinci's is that the patient is outpatient observation. They're not actually booked into the hospital until midnight on the day of surgery if they stay that long. They don't stay that long most of the time. I mean, I try to get people out of the hospital same day. But the ones that do stay over for whatever reason, their actual length of stay, they're in outpatient surgery through the day. If they have to go to the floor, the hospital admission starts at midnight, and they all go home at 7 or 8 the next morning. So they're in the hospital officially 7 or 8 hours, but they're really in the four walls for about 24 hours.
Gotcha. Next question from Dr. Ali Gomi. What percentage of davinci hysterectomies at your hospital are discharged the same day?
I don't know as a whole over all of the surgeons, but mine is about 20%.
Our same day. Okay.
And I do. The more da Vinci you do, the fewer hysterectomies and the more conservative surgeries you're going to start seeing as a percentage. So you'll see more and more endo cases, difficult, locked pelvis endo cases. You'll see more and more myomectomies, uterine conservation. All those patients go home the same day. So you'll see that your da Vinci cases as a whole, a good 50, 60, 70% of them will all go home will go home the same day.
Got it. Next question from Patrick Flaherty. If the vaginal approach has not been universally adopted, how do you know whether vaginal at proficiency has actually been achieved?
Good question. It's interesting he brings that up because in about 14 years ago, a payer awarded our practice, you are the lowest cost vaginal hysterectomy of any of our providers. Well, that's great, so maybe we achieved proficiency. I'm not really sure. But I tried to send those patients home the same day as well, and we did most under regional anesthesia, which you can't really do with da Vinci, but there were methods to get the vaginal patients out quickly too and have great outcomes. Personally, I started, doing da Vinci's to say, well, that 15-20% of abdominals that I was still doing, this was the replacement. It took me, when I started in 2005, to kind of get 3 years into it, maybe 2008. I said, these patients, even compared to vaginal, they use less pain medicine, they go to work quicker, They're happier. They say, my gosh, I can't believe that I put off a hysterectomy this long. I just personally saw more and more and more and more patients have those kinds of outcomes. And then as my davinci practice grew, I started getting more and more difficult cases that I probably couldn't have done vaginally. And so my shift has been more toward davinci. I still do vaginal surgery. I probably now am about 80% davinci and about 20% vaginal. So, and I do maybe, I don't know, 5 or less laparotomies per year. So, you know, there are people who are very proficient vaginal surgeons who get really good outcomes. I would like to say that based on, you know, that information I gave you from 14 years ago, that my practice reflected that, and I've just made a shift based on my subjective view of the patients to davinci.
Great. Next question from John Patry. Does the costing method being presented attribute the cost of the service maintenance contract and single-use davinci instruments directly to davinci patients, or is the cost averaged across the entire surgery department?
The cost ratio is a blend in this data, but when you split it out, you don't see a giant difference. So when you put what is the service contract now, $150,000, give or take a little bit. When you put that into a $60 million budget for surgery, it doesn't move that CCR dramatically. When we looked at splitting the CCR out specifically for the davinci cases, it was 2/100ths of a point higher. So that will be addressed in our study. We do use 2 different CCRs for what we're going to try to publish in the spring next year, but in this data it does not. And in reality, it doesn't make a giant difference in the outcomes. Okay.
Next question from Robert Stansbury. Are the robot instruments being charged for, and if not, how are the additional instrument costs accounted for?
The instrument costs, the reposable instruments, are accounted for in our department as instrumentation. So when you buy, say, clamps, those clamps are reused from patient to patient. We look at the reposables as reusable with a defined lifespan. So those go into instrumentation, and they're not line item divided out to the patient. We do not charge and add a charge on for reposable costs, but that cost is reflected in that CCR as the overall departmental cost, just like any other instrument that the department would buy.
Gotcha. Okay, we got a couple more we'll try and get through here before we sign off. From Patricia Vischer, the closest robot is 16 miles from my hospital. I am still doing OB and need to stay near my hospital. Do you think a 16-mile separation is far enough that I could encourage my institution to purchase a robot?
2 of the robots in Green Bay are in hospitals that touch each other. They physically touch each other. I know that's hard to believe, but there's literally nothing but a wall separating them. And on 2 floors, you can walk between the hospitals and not know that you've walked from one end to the other, and they have competitive robotic programs. So I would say 16 miles is plenty of distance.
Next question from Matthew Desmond. What was the tipping point for purchasing your second robot? After the cost analysis was completed, was there a certain volume the administration was looking for?
Yes. When we said when we start approaching 400 cases, we're going to have access issues, and people are going to, start complaining about getting on the robot. There's going to be limitations in providing, booking slots and things like that. So we used a number of around 400 cases. We, I think, pulled the trigger. I have to go back and look, but it was in the 300s when we saw that coming. So the second system, added second SI system, it was around 400 cases. So that's about where we were. We said that once we hit about 750, the third system should be looked at, and we're going to be over 600 this year, and the opportunity to have a third system was also kind of market-driven in our hospital, so they jumped the gun about a year early based on the budget in the hospital, and it was due to really some other goals within the hospital system, like single-site surgery. Not only GYN, but general surgery has taken off with single-site in our hospital as well.
Okay. Next question from Padma Kandadai. How many cases does a hospital have to perform to break even on the initial capital costs, including the maintenance fee?
Well, that's a tough one to analyze because you can look at it every different way. But if you took, $1.5 million and divided it by 2,000, you'd come up with absolutely the worst case scenario, because we make $2,000 extra per case by doing it on the robot. So whatever that number would be, the worst case scenario. Now the hospital looks at it differently. They look at growth over other hospitals. They look at overall surgical volume that they have to include in there, that they're attracting from other hospitals. They actually factor their marketing for the robot into that as a cost. So I don't, that's a tough one to say. But just on a simple calculation, $1.5 million divided by 2,000, whatever that comes out to be.
Okay. Next question from Chris Benson. How many for proficiency in GYN?
I think that's a good surgeon who sticks with it and doesn't spread their cases out. 20 to 25 cases is a good number. I think that everybody should. I still go and watch cases. I'm going to try to go to New York and watch somebody in November, and I've done hundreds and taught other people. So I think that once you commit to this, it doesn't mean that you quit watching and you quit learning. And really that first step is, after you've kind of gotten through that initial learning curve, is to go watch someone who's super good at it and super fast, and an advanced case site observation at around that 25 mark, and you'll see people, the light goes on even more. Oh my gosh, this step or that step, they suddenly, it just clicks in their head, and they're that much better when they go home.
Gotcha. From Kareem El-Sawi, does it make a difference if the patient stays one night versus same-day discharge?
In cost, it does. And that's one reason why my at-proficiency or lower cost to the hospital than that learning curve, because there was more patients that spent the night over, and even a couple that spent the second night because of some issue during that learning curve. So definitely, the faster you can get the patient out of the hospital, once they leave the doors, there's no ongoing cost. They only cost money for the hospital when they're in the hospital. So as quick as people can get them out, the better.
From Jeff Wong, in your cost calculations, what are your assumptions for the depreciation of the robot, and how many years of machine life?
I think our hospital uses a straight line 5-year. I'll have to double check that, but if you send me an email and ask me that same question, I'll confirm it with the hospital, but I think it's a straight line 5-year deduction.
Okay.
And that deduction becomes a cost to the department, which factors into that CCR.
Gotcha. Follow-up question from Dr. Visco. So none of the costs per patients reported in this include the cost of reposable instruments?
They do, but they show up not as a line item cost on the patient's bill in the charges. They show up, let me go back, in this number right here, in this CCR. So that's where the equipment costs show up. We don't line item those on the patient bill.
Two more. From Kerry Weissman. Our medical center is pushing back against single-site procedures. How do you sell this to your administration as profitable?
Again, faster recovery, in and out of the hospital quicker. I would have to look at instrument costs, but you're only using 2 reposables per case as opposed to 3 to 4 in multi-port surgery. I've got placeholders for single site. If you noticed, we're accumulating volume in general surgery for choles, so I'm going to keep that data and look at it, and we'll evaluate it once we get into it. But they saw it as an opportunity because GYN is the biggest driver of volume to add single-site surgery before anyone else could even think about it in town.
Gotcha. Follow-up question from Jeff Wong. Does your hospital promoter advertise your robotics program, and what programs have been proven to be most effective?
Yes. Actually, there's been 2 waves of promoting. If you remember this decline in volume over the first several years, they just assumed that because they were first to market in 2005, they had it cornered. When the hospital immediately adjacent touching it that I mentioned added robotics, they saw their volume get diluted, and then it went down again. We created after that not just a marketing effort, but it was an overall effort to say, are we going to be the very best at this? If we are going to be the very best at it, we need a multidisciplinary approach. So we had a robotics committee on the medical staff. We had OR people involved and anesthesia people. I think COMIGS does a great job, if you're familiar with that, is they involve the ER, because if these people come back, the ER needs to know, is this something serious that needs to be readmitted, or do they go home? So we looked at it as a comprehensive kind of approach to clinical quality, and then say, go tell our story. Go say that we are truly the leaders. So the messaging from the hospital is, the robot is a great tool, and everybody in town has one, but it's the person driving the robot that counts. It's not really the robot. It's just a tool. You have to be really good at that tool. So I think that's kind of the messaging that they put in the market, is they solved their clinical problem. They focused on it internally with all the players, and then they went and told the story, and the program took off. Patients responded to it.
Got it. Last question, which was asked by a number of people, including Lisa Young. Can we have this PowerPoint by email?
No. It's been very, very hard. This is not my data. This is the hospital's data, and I don't work for the hospital. I'm not associated with them in any way other than I'm on their medical staff, and it's been really hard. I think that this is being recorded, right, Jonathan?
It is, yes, and as long as Bellin is okay with us putting the recording up, we intend to do so.
Yeah, so at some point it's going to be posted, but they, over the past year, have been really uptight about sharing, like, this is what we charge for hysterectomies, this is what we get paid for hysterectomies. They've been really uptight about sharing this data. But when I showed it to them from this perspective and said, this is why we're so good with the cost, is the clinical quality, they've been okay with actually showing it. They were very resistant to even showing it to begin with. So it's hard for me to say email it. I've got them to sign off on doing this webinar and recording it, but not to just email it all over the country or leave handouts when I go speak.
Yep. Okay. And to that end, folks, we have recorded tonight's webinar. It will take us a couple of weeks to kind of process the video and audio and merge the 2 files and then get it up. If you are a member of the davinci online community, which you'll need to be to access this, once it is placed on the online community, I will email everybody who is registered a link to be able to go ahead and download that. With that being said, we are 18 minutes over the hour. Dr. Coussons, thank you so much for your time and your willingness to entertain questions and for your expertise on the subject matter.
No problem. Thanks. Thanks for everybody for the thoughtful comments and being interested in this topic.
Thank you all. Have a very good night.